we know worldwide, as on 14th of May, we have about 4.35 million cases of COVID-19 across the globe. But unfortunately, there's another subset of population of 18 million across the globe which have active cancers, and they are currently requiring treatment for their active cancer. So what we have to figure out is who are these patients and what are the type of cancers. So first thing what we do is to find out whether they are actually aggressive cancer like gallbladder or pancreatic cancer or lung cancer, which if we waste time then can grow aggressively and can actually have long-term consequences. Or the second group is hematological cancers. Now hematological cancers primarily includes leukemia, lymphoma and myeloma. Now this leukemia, lymphoma are the subset of cancers which are completely curable, and so if treated inappropriately, a waste of even couple of weeks can actually destroy the cure which we could have achieved otherwise. And the third set of patients are palliative care patients. So those patients again require pain management or infection management or nutrition control. So first important thing is to decide the risk benefit calculus. Yes, there's a risk of infection, there's a risk of viral infection, but there's another important risk of actually cancer progressing and becoming incurable. So first important thing is to sit with the patient and the family, discuss the risk and the risk benefit calculus, whether should we treat this patient and when should it be treated, make appropriate modifications. So how we modify treatment is that at our level we probably prioritize teleconsultations, talk to us first, find out how important it is and then visit us. We make adequate changes at our front when elective surgeries at this junctures are possibly something which can be avoided. So what we can do is modify treatment as neoadjuvant chemo or neoadjuvant chemoradiation, which is given in a safe way of delivery. We can switch to weekly therapies, which are actually safer than actually giving very aggressive high doses of 3 weekly therapy. Sometimes we switch to tablet therapies or subcutaneous injections instead of IV. Try to minimize hospital visit, have people going in the house to manage what actually could have been done in the hospital. So blood collection and small parameters can be done in the house and informed to your clinician. Then there's another subset of patients who require transplant. So whenever it can be postponed, I'm talking about hematological transplant or bone marrow transplant. So when it can be postponed, we try to wisely buy time by giving some oral chemo in the time frame. When we are actually planning transplant, importantly, we should have the donor ready. We should have stem cell collected adequately in time, probably have a backup donor. At this juncture, we also have a lot of issues with blood product support. So have blood product adequately reserved before starting high dose chemotherapy and transplant. And these are the modifications which we do normally. We have to focus on infection control. We have to focus on making sure not just the patient but the family is covered, and they are doing universal precautions like social distancing, avoiding crowded places, adequate use of personal protection equipment, making sure that they don't expose themselves to any risk, adequate hand hygiene, which is technically called as mindful hand washing. So it has to be mindful, adequately spending time, it cannot be obsessive. And also an interesting advice by us would be avoid overuse of media. Avoid information overload, which can actually stress you more, will probably cause more negative effects on the entire plan. So important to understand is cancer is something which requires attention right now. This cannot wait and should always be focused on.